Next up, we have Professor Ruth Dobson, and she is a professor at the Centre for Preventative Neurology at Queen Mary in London, and another super mum after one of our first ones. I think she was arriving after some childcare this morning. So, but she also picked up an award from the Royal College of Physicians here as an emerging woman leader of medicine and science, and she's going to talk to us today about environmental factors and social determinants of health in MS. So thank you so much for coming today to talk to us.
So thank you very much. I got slightly panicked about getting here this morning, trying to get my 6-year-old out of the house, but we made it. But thanks for inviting me to come and talk. When I was first invited, my initial response was, oh, multiple sclerosis, that's not really neuropsychiatry. But I have been convinced by the organisers that actually there are a load of commonalities. And as I sat down to actually write this talk, it became really apparent that that multiple sclerosis is an archetypal complex disease. There are influences from genetics, there's influences from the environment, which both impinge on susceptibility and severity, in common with many psychiatric diseases. And I think sometimes within neurology and psychiatry in the UK, we sit within two separate camps. And I think this meeting is great because it enables people to think across the two camps. My other sort of thing to disclose at the start is I wrote the abstract a little while ago and then sat down to write the talk and looked at 25 minutes and just thought, what have I done to myself? This was not a good idea. So it is a fairly whistle-stop tour. I don't aim to cover everything around environmental factors and social determinants of health. I can't, in some ways, don't do either justice, but really wanted to give an impression of actually the separation into environmental factors and social determinants is something that's a completely artificial distinction, and we need to move beyond that. So I thought I'd start by saying something about multiple sclerosis and the population that I work with. So many of you will recognise Jacqueline Dupre, and 10 years ago in MS clinics, you said to people you have a diagnosis of multiple sclerosis, they would say, oh, that's what Jacqueline Dupre had. Will I be in a wheelchair? And MS is really not that. So these are all people who are living with MS in the UK at the moment. MS affects people from all different backgrounds. It is a disease that has changed immeasurably over the past 20 years due to the availability of therapy and other factors, which we will come on to. And really, we are starting to move beyond this traditional view of disease, but still there is lots of work to do. So in terms of MS epidemiology, it affects 3 times as many females as males in the UK. The sex ratio was actually about 1-to-1 in 1900. And there's been this dramatic change, this dramatic relative increase in women. And I think this really starts to speak to some of the complexity, because this is not just about the changing disease. This is also about changing healthcare systems. This is about paternalism in medicine. This is about how people disclose diagnoses to people. And it's also about how pharmaceutical industry and the availability of therapies really changes a disease, as we have had effective therapies increasingly available over the past 20 years. People are getting diagnosed younger, people are being diagnosed with milder disease. Diagnostic criteria are changing in order to accommodate early access to treatment with long-term beneficial aims. So it just helps to start to set the scene that this is both a complex disease in causation, but also a complex disease in terms of actually who's diagnosed with MS. So I was asked to talk about essentially why people get MS. And when I went through the literature, it's really, in some ways, depressing that things haven't moved on very far since 2010 when we wrote this review. Actually, there aren't really many more factors that have been identified, although we understand a lot more about these factors. But what this really shows, and I really like this diagram, because it shows that actually this is something that starts in utero. This is not a disease that people acquire in adulthood, even though the diagnosis is predominantly in adulthood. And we'll go through some of this, but there are changes in utero that then accumulate during childhood. And most of these changes alter somebody's risk. None of them are potentially directly causative in a Bradford Hill type model. And you get this sort of almost sliding scale where you see peripheral immunological changes first, then start to get changes within the central nervous system way before the clinical development of MS. We'll come on to talk about, well, you see something called an MS prodrome. People with MS are unwell for some years prior to their diagnosis. There are increased GP visits, there are increased healthcare contacts, not with neurological symptoms, but with a range of symptoms. So this is something that's building up. And this really is thinking about, again, who gets MS. And I showed you the first slide with the sort of typical white European female. And I think one of the preconceptions that I really wanted to overcome in this talk is that actually it's not that simple. So this is American data, but what this really shows, the way that I interpret this, is that you're much more likely to get MS if you are female black, female non-Hispanic, non-white, than you are if you're male. So actually MS is a disease that affects everyone. And I think even if you go out to the medical students in my medical school, say, start off all their essays about multiple sclerosis saying multiple sclerosis is a disease of European populations. It's absolutely not. And part of the reason that this preconception gets sort of perpetuated is because people don't do the studies, they don't look at things, and also because of clinician bias. And actually, there's evidence out there that people from different ethnic backgrounds have a longer route to diagnosis and then delays in treatment initiation because of this bias. So our bias affects who we diagnose. So I said I was going to talk about factors precipitating to multiple sclerosis, and then I sort of wanted to walk through life. So the first thing is early life. I was really interested to hear that SUDEP deaths go up in April due to sort of coroner funding. Interestingly, with MS, you're more likely to be diagnosed with MS if you are born in the spring and summer months, if you're born in April, May, and much less likely to be diagnosed if you're born in November, December. And this has always been put down to vitamin D levels, so neonatal vitamin D levels in the second and third trimester when the immune system is developing. So if you're born in November, your immunological development in utero is in a state of essentially high vitamin D levels. Whereas if you're born in the spring, your in utero development's been in winter. Until quite recently, this has all been quite theoretical. But more recently, we've actually had really neat studies from Scandinavia where they've looked at neonatal blood spots, so blood spots taken from babies in the first 48 hours of life. And the first thing, and this is probably the most important thing, is you actually see that babies, their vitamin D levels mirror that of the general population. Their vitamin D levels are higher in the summer, lower in the winter. And the vitamin D levels overall, blood spots are a very good way of doing it. They don't decrease over time. And I mean, there was an argument in the paper, which I'm not sure I buy, that the difference was greater here with this period when people are less likely to be diagnosed with MS. And I'm not sure there's much of a difference. So moving through life, as I said, this is a bit of a whistle-stop tour through life. EBV is one of the factors that's most commonly associated with MS. So if you look at large population-based studies of multiple sclerosis, 100% of people or 99% of people are diagnosed with MS are EBV positive, about 95% of the general population. Very, very complex to prove causation with that kind of proportion of the population, particularly where you have different tests with different sensitivity and specificity. This work got a lot of press when it came out a year ago. It was incredibly hyped. It was an American study, and what they did is they looked at US Army recruits, and they picked people who had MS, went back through their records, and then selected those who were EBV negative at Army enrollment. So you've got people who've got MS, you go back through their records, you say, well, I want to pick out the ones that are EBV negative, I'm studying this. And they also looked at CMV as a control virus. And they found between people with MS through the green line or subsequent MS, the green line, and the blue line, who are your controls, and differential rates of seroconversion. And actually they found that 34 out of 35 people who subsequently developed MS seroconverted to EBV prior to MS development. But also, and this was the neat bit, is they actually went back and looked at neurofilament levels. They looked at levels sort of that might reflect CNS inflammation and saw that those rise not prior to EBV infection, but after EBV infection, but before MS, clinical MS development. So they used this to argue that EBV somehow acts as a trigger in a susceptible population. There are challenges with these data, for sure. It's the US Army. This is not a representative data sample, okay? So predominantly male. I've already told you that MS is 3 times as common in females than male. So predominantly male, sort of quite a varied ethnic distribution, probably with Black Americans overrepresented compared to others. And but it provides useful information that helps with this. And part of the reason that paper got so much press is it came out the same week as this second paper, which really tried to look at mechanistic reasons. The EBV observation has been there for a long time, but the mechanistic observations really have lagged behind and have sat with fairly traditional explanations around molecular mimicry or antibody targets. Whereas this group looked at sort of clonal expansion of B cells and what they bound. And they found that they bound EBV EBNA1, which is the antibody that's been associated with MS, and glial-cam. Again, does this fully explain it? I'm not sure it does. Glial-cam's actually an intracellular antigen. So they sort of mashed up the cells and then found they bound to something inside the cells. And I think probably within neuropsychiatry, we're very aware of actually the challenges with intracellular antigens and their specificity and their role in disease. But we are edging towards mechanistic evidence. Other factors that are important in EBV, in MS development, so adolescent obesity is a big one. This is work that Julia Patpour, who's now an academic fellow, but very talented, did when she was a very talented student, showed that in the USA, by 2035, about 14% of MS risk will be attributable to obesity. This is a public health crisis. In the UK, we're not quite as bad as the US, but we're not far behind. It's about 10%. So it's not 10% of the MS population are obese. It's saying that 10% of your overall risk of MS is related to, at a population level, is related to obesity. We looked at this for obesity and smoking, and you see the sort of graphs change as people stop smoking. But of course, BMI is a relatively crude measure. It doesn't differentiate between fat and non-fat tissues. I think we all sort of are aware of people like the gladiators who have hugely high BMIs, but not an inch of fat on them. It's all muscle. And it doesn't differentiate between fat stored in different parts of the body. So when we look at these things, we need to be really careful actually what this data is showing, because a lot of the observational data just looks at BMI and is a very crude measure. And BMI in kids is not measured in the same way as in adults, and actually adult measurements don't translate well to children. And it seems to be sort of whole body fat. It doesn't seem to be increased height or non-fat related mass. It doesn't seem to be particularly sort of central obesity, as is associated with diabetes and cardiovascular risk. And there is a biology behind this, and I'm not going to go into lots of detail about it, but we see from breast cancer and other studies that fat cells are immunologically active. They're not neutral. It doesn't just sit there as fat. They are doing things within your immune system, particularly in an estrogen-dependent manner. So it fits in again with the sex ratio that we're seeing in MS. But with obesity, the timing of exposure is so important. And this caused me lots of thought, because if you do MS clinics, it's not an obese clinic. I mean, I do my MS clinic alongside where there are renal clinics and cardiac clinics. My population are definitely a different body habitus. Some of the other clinic patients, and it's actually timing of exposure. And this is where understanding sort of traits that contribute towards complex diseases becomes really tricky, because it's not just a yes, no, it's a when. It's a when and how. And so this is work that Luke Hone, who's an academic F2 working with us, did. And it's really kind of later childhood and adolescence. It's not early childhood when the obesity seems to influence your risk. So can we start to chip away? Can we start to think about actually when these things are useful, are important? And it's with smoking, I mean, we all know that smoking at any time is bad. Smoking is very consistently a risk factor for multiple sclerosis. But the question about smoking and severity is one that's really vexed people. Is it just a risk factor? Is it susceptibility, or is it susceptibility and severity? And more recently, there has been data that's come out that show not only does it drive severity, but actually if you stop smoking, you can reverse things. So it probably has a dual role, and that's probably through its immunological actions in terms of susceptibility, and then its vascular actions in terms of severity. So the same risk factor may act differently and via different mechanisms on severity and susceptibility. And I think, again, when we're thinking about complex diseases, thinking quite hard about, well, what's the mechanism? Does this tell us what this is doing, how it's working, what the impact of changing behavior will be? Because with a susceptibility thing, it's once you've started that cascade, can you switch it off? But if it's actually through ongoing other mechanisms, you may be able to reverse some of the changes. So I've talked a bit about MS risk factors, but I just wanted to flag some of the work that goes back to my original slide about who gets MS. And one of the really important questions is actually, do MS risk factors act equally across groups? So Ben Jacobs did a lot of this work within UK primary healthcare data, where we looked at almost 10,000 people with MS and over 100,000 controls, really to try and understand, is there something different about people from different deprivations between rural and rural and urban groups around the action of MS risk factors. And for the sake of time, I'm just showing the ethnicity work, but essentially we found that a risk factor is a risk factor and MS is MS. And sometimes we run into trouble with overthinking this, and it's also about confounders, which we'll come on to. Because we looked at socioeconomic status and risk of MS. And this got really interesting. This gave quite a lot of pause for thought. So what we see is when we look at socioeconomic status at patient level, so this is at an individual level, how deprived you are. If you are not deprived, your adjusted odds ratio was the reference as one. If you are very deprived, so deprivation levels of 4 or 5, so the most sort of deprived 2 quintiles in the country, you are less likely to be diagnosed with MS. I've just told you that smoking, obesity, poor diet are risk factors for MS. This didn't make sense. It didn't make sense. But then, of course, it makes perfect sense because it's all about access to healthcare. It's all about how people are able to navigate to reach a diagnosis. And I mean, I work in Whitechapel now. I used to work in South London. I live in South London. And from personal experience, I can tell you, navigating healthcare is really, really hard. Even if you know exactly how to do it, even if you've grown up and worked within healthcare, it's still really, really hard. If you live in deprivation, which of course is a surrogate marker for not being, not necessarily speaking English as a first language, low educational attainment, all kinds of other factors, I can't imagine how difficult it is to navigate healthcare. So these people probably should be out here somewhere. They should probably have a much higher risk of MS. So it's not just that we are kind of not diagnosing everyone equally, we're actually sort of doing even worse than that. And then it got really interesting, because then we looked at the GP level of deprivation. So this is individual, and this is looking at where the GP practice is located. And actually where your GP practice is located has no influence on your odds of getting diagnosed with MS. It's all to do with the person. It all comes back to that person. And this is sort of some of the interest in social determinants of health comes from. So I mentioned I work in Whitechapel. Here is Charles Booth's poverty map of Whitechapel. For anyone that works in London, I recommend going and looking at these for your area because they're so interesting. So Whitechapel High Street, so the hospital's kind of here. The High Street was middle class and well-to-do, but you go like one street back, this is Commercial Street, go one street back just off Brick Lane, and it's lowest class vicious semi-criminal. So, and it doesn't feel like Whitechapel's changed very much a lot of the time. Although this is Whitechapel now, it's an absolutely brilliant place to work. But what we do see is we see everything. We see people from every different background. So this is the old hospital, it's now the town hall, the new hospital's kind of here. The houses behind the hospital sell for about £2 million at the moment. I looked them up on Rightmove. And on the other side of the street, you have people with sort of no access to healthcare. It's really brilliant. And so this really kind of got me thinking, well, what about disease outcomes? Because people don't have equitable access to healthcare. And in MS, and I'm sure in many diseases, we increasingly understand long-term implications. Our studies enroll from specialised healthcare services, and generalising those findings is challenging. And correcting for socioeconomic status in a population who already access healthcare really misses the boat. So social determinants of health, the conditions in which people born, live, work and age, it's everything. It's your friends, it's your family, it's your community, it's your access to transport, it's your education, it's absolutely everything. And so I just wanted to run through some of those. I'm aware we're tight on time. The first is gender. So there is a lot of work out there about gender and healthcare access at the moment. The bit that doesn't really get spoken about is actually sexual and gender minorities. So we talk a lot about feminism in healthcare. The healthcare narrative is slowly edging towards actually even more sort of neglected groups. And this is a real challenge in MS, and that is a separate talk, which at least one person in the audience has heard before, which I'm not going to give again, but it is very, very different the care potentially and around gender-specific factors like pregnancy. We know that MS symptoms vary by age, sex, race, and ethnicity. People have different lived experience of their disease. This should not be a surprise to us. We're all different human beings. That's why being a doctor working in healthcare is absolutely brilliant. But actually, this impacts differently on quality of life. So I find this study just fascinating. So the relationship between disability and quality of life is different between males and females with increasing disability. So it flattens out with females. Once you sort of start having walking impairment, actually the impact of MS on your quality of life seems to flatten out. With males, it pitches down. That tells us a lot about actually our society and the roles that people play within society. And actually maybe people need different care. Maybe people need care that's focused towards their individual needs. That shouldn't be a really controversial thing to say, but it somehow feels like it when you frame it around personal factors like gender. I talked a bit at the beginning about the role of ethnicity and race and susceptibility. There's a lot of studies looking at severity of MS, okay? And these studies almost exclusively come from America, almost exclusively looking at African Americans, showing that essentially on MRI metrics, on clinical metrics, people from African American and other minoritized racial backgrounds have worse outcomes in MS. And so there's been this whole hunt for why do people do worse? What is it biologically? Is there a biological difference? There's not a biological difference. When we look in the UK, we see no difference across people of different ethnicities. This is racism within healthcare. And actually, I think when you're thinking about complex diseases, we need to be really careful about saying, well, there's always a biology. There's not always a biology. Biology sits within structures. Okay, so we did this work within a large population-based study of MS. And we saw that both in terms of onset, there does seem to be a bit of an earlier onset in South Asians that we were struggling to explain but trying to think about. But otherwise, the two groups look very equal between different ethnicities. But in terms of disease-specific outcomes, so in terms of doing quality, so we did quality of life, impact scores, disability measures, fatigue, walking, it's completely flat across people with all ethnicities. The other one, this really is just where it's trying to get people thinking rather than giving answers, is employment. We know that employment's a big driver of healthcare outcomes in MS and other diseases as well. I tried to draw out a sort of cycle and well, I didn't quite give up, but it got more and more complex, and then my PowerPoint skills failed me. But essentially, MS is associated with increased unemployment, but also so is disability. But unemployment is associated with more disability because it's harder to access your healthcare if you're unemployed and you can't afford the travel. So the mean distance travelled for people to receive treatment for their MS is about 45 minutes in the UK. Okay, so people travel almost an hour to get their treatment in many parts of the UK. We have the MS risk factors which may associate with unemployment but also be affected. So you start to get into these very complex webs. But really, I think it all comes back to healthcare access. And actually, this is at the centre of a lot of the findings that we find around complex disease, particularly on factors driving severity. We search for this biological underpinning, but we miss the elephant in the room, which is actually if people can't get into healthcare services, then their outcomes are much worse if they are delayed. And rather than thinking about people being hard to reach, we need to think about how our systems are set up to reach people. Because as healthcare providers, we're the privileged people. We're the ones who have the ability to do that. You don't have the ability to do that from outside the room. So as I come to the end, I think I've almost kept time. My final thoughts really are that it's increasingly severe that for the most part, MS is MS. We need to support people to be able to access diagnosis, investigation, and treatment in a timely manner. But it's not easy. It's really not easy. It's really, really hard, actually. And there are huge barriers to access, which can be personal, they can be structural, they can be biological, they can change over time. And when I talked about healthcare access, I talked about sort of our privilege. And I show this slide quite a lot now because I find it really interesting. I find it really interesting to reflect on in consultations because we all sit somewhere within this wheel of power privilege, and we sit in different places depending on the context that we're in. So when we're there as a healthcare provider, the amount of power that we hold, changes. And people feel very different in terms of their power in different environments. This is not an absolute, it's very context specific. And I think with, when we look at sort of social determinants of health, we just need to be so reflective about this. And we need to be so reflective as well about equity, that people need different things. It's not one size fits all. So I hope I've convinced you that my attempt to separate environmental factors and social determinants of health when I thought about writing this talk was completely flawed, and actually they overlap and influence one another, and trying to separate them out is artificial. And actually we need to think of them in the same way, particularly in the context of complex disease. Factors can affect susceptibility, severity, or both, and they can do so in different ways. And just because a factor affects one in one way might mean it affects a different one in a different way. Pathways leading to MS are complex, and I think you could change MS for a huge number of diagnostic labels, and that it's not a sort of particularly specific statement. But we really need to think carefully about who we include and exclude from causation work when we're looking at work that looks at susceptibility and severity. It's very easy to just say, oh, well, I'll correct for that. Oh, there's missing data. And I didn't show you some stuff where we've looked at missing data. And of course, missing data is completely biased. It actually tells you something about the population. It tells you about who's taking part. And diverse cohorts are important for many reasons. It's not always easy, but it's really hard. And I just put this up so that hopefully people would like me. But psychiatrists are probably far ahead of neurologists in this area. So thank you very much. And that's it.
Great. Thank you for a brilliant talk covering such a broad area, and obviously that, highlighting that sort of inability to divide social and environmental, but also neurological and psychiatric, as we in this audience we're all persuaded of. So probably got time for one quick question. We're a little bit over, but if there's a burning question, anyone in the audience, yeah, Harry, isn't it? I don't know if you've got a.
Thank you. That was a really fascinating talk. So I was really interested by the relationship with socioeconomic status, and showing that you found the opposite result really to what you were expecting. Lower socioeconomic class seems to be protective. You see a similar pattern in Parkinson's disease, and I've always assumed the same. It's about healthcare access, it's about diagnosis. But then you see the opposite in Alzheimer's disease, where actually lower socioeconomic status is a big risk factor, even though it has the same kind of risks of delayed, lack of awareness, lack of diagnosis. I just wondered whether there was kind of a more complex answer to this question than just healthcare access, and whether it's relationship with ethnicity, is it genetic factors, or what you think might.
So the Alzheimer's disease is a really interesting one. It's a really interesting one, and as you say, lower socioeconomic class, if you look at ONS records, increases your chance of having a diagnosis of dementia at death, at the time of death. I think one of the challenges and one of the differences is that both Parkinson's disease and MS are sort of diagnosed, if you like, as pathological diagnosis, whereas dementia is a syndromic diagnosis. And so dementia is a label that's sort of applied across lots of different things. It's not just one thing, and unpicking that is quite complex, because my understanding of the Alzheimer's studies was that it was mainly all-cause dementia rather than pure sort of pathological AD. Because actually when you look in communities, there's really differential access to biomarker tests for Alzheimer's, where essentially if you're seen in very specialised centres, you get Alzheimer's testing. If you're seen in community memory clinics in East London, I think we had one person in a year having access to it. So there's a real kind of dichotomy there. So I think I agree that it is about unpicking that and really understanding what's gone in and what it's telling you. That doesn't quite answer your question, but it's sort of, it's really hard, I think, is the short answer.